Hello, dear listeners. Welcome to another episode of Follow Your Path. My name is Abdul Abid, and today we will be talking to Dr. Kirill Lyapichev. He is the Division Director of Hematopathology at the University of Texas Medical Branch in Galveston. I am joined by my co host, Meredith Herman. Welcome to the show, Dr. Lyapichev.
Hi.
So, starting off, we wanted to ask you just tell us about yourself, where you grew up, where you went to medical school, how did you end up in hematopathology?
Hi. So my name is Kirill Lyapichev, and I grew up actually on the north part of Russia, next to North Pole, on the border with Finland and Norway. And it was a little bit too much of snow and cold for me, so I decided to move to Texas. um, but yeah, because on the north part there is not a lot of people, not a lot of big academia places. So for my training, I moved to south part of Russia and I finished Voronezh State Medical Academy. Then I start my training in surgery, but I didn't really like it, and I was invited to participate in research at in the United States and in the University of Miami, and I used this opportunity to move and to see how the research is done in one of the best places in the world. So during my research time, uh, I realized that I would like to try and pass my medical boards in the United States, which I successfully finished. And during match process, I decided to stay in the same place, and I matched at University of Miami. So, and there I basically finished my APCP or pathology training, University of Miami. So during this time, I met Dr. Vega and Dr. Chapman, Dr. Ikpat, that's hematopathologist. And I believe that the influence of attendance are significant when you are choosing on your path, like charisma, the interest in the subject, and the teaching. So I was impressed by uh, my hematopathologist at University of Miami, especially Dr. Vega, and I decided to do the same. And Dr. Vega advised me to apply to MD Anderson, which I did, and I believe for that MD Anderson Fellowship, Hematopathology Fellowship, it's the best, not just in the United States, it's the best in the world. And because how they teach, how they uh, treating fellows, uh, and they are investing in fellows. And I was amazed. And so I moved to MD Anderson, and I spent there 3 years. I finished hematopathology fellowship first year, advanced hematopathology, and then I stayed for another year in molecular genetic pathology at MD Anderson. After finishing this training, I decided to stay in Southeast, and there was a position offered by UTMB, which I accepted. It was um, one second. It was director of hematopathology. So now I'm director of hematopathology at University of Texas Medical Branch. So that's my path.
Wonderful. Thank you for sharing your story. It sounds like you've been all over the world and had a bunch of different experiences all over. So that is incredible. Uh,
Yeah.
you kind of touched on this already, but we want to talk more about mentorship. Was there a particular faculty member or mentor in your path to in medicine and pathology who particularly inspired you to go down this route?
To hematopathology around.
Yeah.
Yeah, I would. I would suggest, I would say it's Dr. Vega. He was a faculty at that time at University of Miami, and uh, relatively recently he came back to MD Anderson. So, and he became my faculty at MD Anderson. I would say he kind of inspired me on. He showed me the bright side of hematopathology. I would say Dr. Ikpat and Dr. Chapman, they did their part. I think they solidify my decision on going to hematopathology world. And when I chose it, like, and I start my fellowship, I was amazed by all faculty at MD Anderson. It was my best time of training. Like, I, it's hard to compare with anything. It's like so much of support. I have never seen something like that. And if somebody thinks about doing hematopathology fellowship training, I there is no brainer. That's the best place. That's the best place. Dr. Medeiros, Dr. Miranda, Dr. Corey, um, Dr. Sawan, Dr. Lagavi. I mean, there is 36 faculty, and most of them are like very supportive. And I'm kind of scared not like forget to name somebody, but it's hard. They're 36, and all of them like very nice. And there is a lot of opportunities to do research. There is everyone has the different style. You can choose your style based on their style. So my style is basically consists of uh, things which I found and I like it from the different faculty. And yeah, I was trying to take the best out of them.
Nice. Wonderful. So, Dr. Lyapichev, if you had to talk to a junior resident, or and which is something that you already do, and or medical student, a fourth year medical student, what would you tell them about hematopathology? What makes it so unique?
So I think it's one of this specialty. I'm not sure if there is another specialty which is sitting between APCP, clinical pathology, anatomical pathology. Because being a hematopathologist, you cannot be on only CP world or only on AP world. Uh, you need to know both. And both parts in the department depends on you. Because anatomical pathologist, there is a biopsy of stomach, biopsy of the liver, biopsy of lymph node, they're going to you. The clinical world, there is CBC numbers are strange. There is some kind of coagulation problems. They're going to you, and you're helping everyone, and you're kind of in this special position when all department is dependent on you. If you cannot take a responsibility, if you think that you are not very confident, I don't think it's the right place to go. But in hematopathology, you need to know pathology. You need to know both parts pretty well. But I mean, it's a unique specialty. It's like a puzzle. You always try and if you're answering the question, you need to put the puzzle together. You need to put flow cytometry, cytomorphology, molecular, and all these parts you need to remember and you need to know. But it's I know it's hard in the beginning, but then you have this knowledge on base. That's amazing what you can do with your knowledge. That's amazing. And especially it's amazing for clinicians. It was like, oh, how did you do that? And I was like, sometimes you're calling them, it's like, okay, where's your patient? It's like home. It's like call him back or like call 911 because we need to bring the patient back. It's like this patient has leukemia. There was like a lot of cases like that. A lot of cases.
Yeah, that is very interesting how hematopathology is a combination between AP and CP. when you're using a lot of different skill sets between, both those aspects and coming up with a clinical diagnosis. Can you share a case that you found interesting in your career? I know you touched on it with leukemia. Is there a particular case that stands out to you that you'd be willing to share with us?
Sure, sure. So today is Independence Day for Mexico. I would probably will talk. I will tell you one case about Mexican boy. Uh, there was a boy on the bus from Mexico, and he had a sore throat, and he came to our institution with a sore throat and to check for infection or something like that. They sent CBC, and they realized that he doesn't have much of cells at all.
Oh.
Um, so there is a very low amount of white blood cells. Hemoglobin was around 5, I would say. Anemic, no platelets, like nothing. And that was probably cause of infection because he doesn't have no immune cells, no white blood cells. And they performed a bone marrow biopsy, and bone marrow was empty. So your conclusion is aplastic anemia. There is no cells. What is this? Probably autoimmune process that would the clinician suggested. But I sent the sample for flow, and I identified very small population of blasts. It was beer acute lymphoblastic leukemia, and it was extremely hard to diagnose because patient didn't have cells at all, and it was very hard because it's very relatively easy to confuse a B lymphoblastic leukemia with for hematogon sometimes, and it was very hard uh, case because I need to pull the trigger and say clinicians, okay, you need to treat. Because if it's hematogons, then you're killing the rest of the cells which patient has. This young boy. But after discussing with clinicians, we decided to treat, and he just blew like a flower. His bone marrow just recover, and it was very nice to see these boys' numbers when his hemoglobin start growing, his white blood cells start growing, and we just I think we saved the life of this boy. See, he came for infection and ended up to be having no cells, and we diagnosed very rare B acute lymphoblastic leukemia. And it's probably the clone. It was a clone which was suppressing the rest of the cells. And when we start killing it, it's just the rest of the cells, they start like regenerating again. So that was a cool case. That was a very nice.
Nice.
Wow.
So that's wonderful to know that hematopathology played such an important role in patient care for a patient. So uh, changing gears a little bit, what is the most gratifying aspect of your job? What brings you joy in your job as a hematopathologist?
I, I think I kind of already told you my joy with the last case. It's the joy is then you diagnose the patient correctly, and you tell your clinicians how they need to approach it, how they're supposed to treat this patient, and see the response on the treatment. Then you really see uh, what's your impact on the patient care, and to see clinicians' eyes, especially when they didn't even think about such a possibility, and you're telling them, okay, that's this, and you need to treat it, and you need to treat it as soon as possible. I have another case. There was a lady came with a breast mass, and they thought it could be breast cancer, and I diagnosed T lymphoblastic lymphoma in the breast as a single mass. And my first call was saying, hey guys, that's T lymphoblastic lymphoma. Send the patient to chest CT scan. And they said, why? Clinicians like, why do you need to do that? It was like, because there is a chance that there is a big mass in the mediastinum, and there can be a tamponade. So there was some kind of delays, and patient was feeling well, and guess what? Lost in follow-up, and in 2 weeks, patient ended up in ICU with heart tamponade.
Oh, wow.
And after that, I told them, I called you. I told you what you need to do. You didn't do that. Now you handling tamponade issue.
Mm.
So yeah, and after that, they like calling me to say, hey, what do we need to do? Or like you're gaining some kind of respect because when you're telling them that they don't expect or they don't think about doing, and they should, they are like really appreciating the help.
Oh, wonderful.
Yeah, absolutely. Hematopathology is so critical, and I'm sure have seen a lot of awesome cases and seen the impact you've made for those patients and clinicians as well. So, switching gears again, leaning more towards um, residents and medical students who are thinking about what subspecialization they'd like to pursue in pathology. Can you elaborate more on what the training is like for going into hematopathology and the fellowship training, and if there's any like exams you have to take for it and all of that?
Yeah. Unfortunately, you do need to take an exam after this fellowship, but I think it's reasonable because it's not easy. The board certification is important, I think, and I believe at some point every fellowship will have a board certification because the amount of molecular uh, now like is growing, and personalized medicine is growing. So you need to know a lot of molecular in every specialty, and it's hard to know everything in depth for every specialty just for a resident. Um, yeah, so hematopathology usually it's 1 year training, but most, like not most, but a lot of places have 2 years because it's very hard to gain all this knowledge, and hematopathology like very heavily depend on cytogenetics and molecular. That's why a lot of hematopathologists doing fellowship in molecular genetic pathology too, because you need to get this knowledge in order to make a right diagnosis and suggest uh, the right prognosis, or like to order specific markers for to help for therapy and so on. So uh, yeah, that's why MD Anderson offering 2 years, which is just hematopathology and advanced hematopathology. I know that some other places doing the same thing, uh, but it's important as well for people who considering going in academia. For community practice, it might be okay because you can always send a difficult case to academia place for concordance or clarification. But when you're in academia, you basically the person like who is receiving those difficult cases. So you need to know what you're doing. So for community hematopathologist, 1 year, if you're planning to go to private practice, 1 year is enough, I believe. If you're going to academia, I think 2 years is probably the best choice.
Oh, great. So, Dr. Lyapichev, lastly, what advice do you have for residents who are interested in hematopathology? What should they study? What should they focus on in their first and second years?
Um, that's a good question. So it depends on the background, like how much already knowledge you have. But I would suggest for hematopathology fellows or last year uh, residents to keep up with literature, uh, because you need to learn more about new markers for flow cytometry. You need to learn more about different mutations and so on, which can be helpful for diagnostic purposes and therapeutic purposes, because you need to choose the markers in your flow cytometry or add another marker based how can you help the community of patients, right? And you are choosing the marker like which has treatment um, purposes. So yeah, keep up with literature. Try to read journals or some interesting review articles. I think that's helpful. That would be helpful.
Oh, great. Thank you very much. That's our show for today, folks. You can find Dr. Lyapichev on Twitter. His Twitter handle is at Kirill Lyapichev, Kirill Lyapichev. Thank you very much for listening to us, and we'll be back for another episode soon.